Hello, everyone. Thank you so much for joining tonight. My name is Julia Mulliken. I'm the Physician and Community Liaison for Buffalo Rehab Group. I am joined tonight by Dr. Joshua Meyers. He is a neurosurgeon from UBNS, and tonight we're going to be talking about all things back pain. So we're going to talk to Dr. Meyers first, and then our physical therapist, Chris Ponichtera, is going to come on after, to go over some simple at-home exercises that you can add into your routine. So, hi, Dr. Myers. How are you?
Good. How are you?
Great. Can you go ahead and introduce everybody to who you are and give a little bit about you?
Sure. I'm Josh Meyers. I'm a neurosurgeon with UB Neurosurgery. I've been with the group for a few years now. I trained here. I've lived in Buffalo for probably 15 years now. I did residency here. I stayed on board with the group, and I primarily focus on spine, but I do some cranial surgery. So,
very exciting, awesome. All right, so let's talk about in broad terms when somebody says they have a bad back, air quotations, right, or an injured back. Can you explain what that usually means?
So that's a very broad term in terms of bad back.
Yeah.
The majority of people with back issues typically have some sort of degenerative arthritis, which is essentially wear and tear on the back or arthritis type changes that come with age. There are some patients that can present with fractures or tumors or infections, and those things are all sort of encompassing bad back, but the majority of patients typically have, arthritis.
And so in terms of the spine, where do you see the arthritis? Maybe I think you have a model, so maybe you could demonstrate for people at home.
So, there are, many potential spots of arthritis in the spine. So if I look at a model, you have the sort of front part of the spine here. You have the discs, which is the, spongy material that allows for motion, but you also have these joints, which are on each side of the back here of the spine, and that allows, in conjunction with the disc, motion. And it's usually at the spots of motion that arthritis can occur. There's also a thick yellow ligament that's sort of in between the bones here and kind of surrounds the joints, and that substance can also play a role in arthritis and overgrow. And when you have either overgrown joints, or you have overgrown disc, or you have overgrown ligament, or you have a herniation, all those things can cause compression on the neural structures, which essentially can result in pain.
Mm-hmm. So you said an interesting word there, which was the herniations, and from my understanding, that's kind of a different classification maybe of a back injury or something, like a herniation or a bulge. Can you kind of elaborate on what that is and maybe how people come to have that occur?
Sure. So, you can have various pathologies of the disc. Certainly there are terms like disc bulge, disc protrusion, disc herniation. Those are very similar, but, they're kind of different things. You can have what's called a disc extrusion, where the material from the disc space actually, pushes out completely from the disc space and pushes on a nerve, and, we would consider that a disc extrusion.
Okay.
A disc protrusion or a disc bulge, we consider that what we call subligamentous. It's usually there's a covering over the disc space, and you can have a protrusion there in which sort of the ligament bulges out as well. That's not, a free fragment extrusion, like the material just coming completely out of the disc space. But all of those things, can, people say, oh, I have a disc herniation, can be sort of encompassing in that term.
And talk to me about, now when people hear this word, it's probably something scary to them initially when they're first hearing that, because usually most of the time then they're going to see you guys to kind of discuss that. Is it something that they typically need to be expecting surgery for right away, or?
No. So, when it comes to surgery and what to expect like that, I would say the majority of arthritic conditions can actually be treated non-surgically, with things like physical therapy and epidural injections, doing traction decompression, seeing chiropractors, that sort of thing, and most things can be managed conservatively like that. The really things that really can't really necessarily be managed conservatively up front, certainly if you have a neurologic acute onset deficit, if you have patients that come in saying, oh, they have a foot drop all of a sudden, or have weakness in their legs, or have problems walking because of weakness or urinary incontinence, those things are certainly usually can't necessarily be treated conservatively a lot of times, but the majority of arthritic conditions most people will have that come through there, but a lot of them aren't even symptomatic, so the majority of them can be managed conservatively.
Yeah, so talk about that too, in terms of a lot of these I think are typically diagnosed by an MRI, right? When should a patient look to maybe get one of those throughout their care journey?
Yeah, so in terms of getting an MRI, I think that, for the routine, degenerative conditions, most people have contacted their primary care physician or, have been going to physical therapy. And, certainly if, you've been going to physical therapy for 6 weeks or so and things just aren't getting better, then it may, warrant an MRI. Certainly if you've had a history of cancer, that should warrant an MRI right away. If you had a recent trauma with sudden onset pain, the things, obviously you want to look for any, traumatic conditions like fractures, that usually warrants an, upfront MRI. Or if you start to have, fevers or, a neurologic, like I said, neurologic deficit with motor weakness or urinary incontinence, those types of things warrant MRIs right away. But for, usually routine wear and tear and, sort of progressive, sort of pain issues in the absence of any, cancer or fevers or anything, it's okay to try, conservative measures, and then, if you fail that, then get the MRI.
Great. Talk to me about, is there any new, so obviously this is a common injury, I think a lot of people have back pain. Is there any new, exciting treatments that you're really interested in, up and coming on the horizon to kind of combat these?
So, I'm a surgeon, so, I look for the surgical ways.
Yeah.
Certainly there are more minimally invasive ways to treat these things nowadays. I think, a lot of patients have misgivings about surgery. They've had, a friend or whatever that had surgery, 10, 20 years ago, and, it was a lot different back then. There's, incisions are a lot smaller now. There's more minimally invasive ways to do things besides, having a big open incision for one level, disease or something that you used to do 20 years ago. Now you can make, small coin size almost incisions and be able to do the things that you were able to do then. But there's a lot of new technology that enables us to do this. I mean, we have 3D navigation, there's robotic technology that we use a lot these days. So there is definitely exciting techniques.
Great. So on the flip side of herniations, you kind of talked about struggling with that degenerative back too. So can you kind of talk through why the low back is prone to that aging that occurs?
So it's really the repetitive motion and wear and tear over time, right? So the majority of degenerative changes in arthritis usually occurs either in the neck or the back, and not necessarily the middle back or the thoracic spine, because there's more motion in those areas. So typical degeneration in arthritis will typically occur usually at levels of L4-5 and L5-S1, and then the cervical spine at C5-6 and C6-7, because that's where most of the motion is. And it's that repetitive sort of using of those joints and that motion that causes wear and tear over time that can lead to these arthritic conditions.
Great. And I think in terms of diagnosis, stenosis is a word that kind of gets tossed around within that degenerative group. So can you kind of talk to me a little bit more about what stenosis is?
Sure. So stenosis is sort of a broad term for just narrowing. And it can be caused by a lot of different things, like what I talked about. What happens is that, with arthritis, the joints, can overgrow in the back, the ligaments can overgrow, the discs can bulge, and all those things can cause stenosis or narrowing. And so that's, what stenosis is.
Great. And then if a patient's struggling with this pain or limitations from these changes, kind of what are their treatment options for those?
So, typically, and, I hate to say as a surgeon because I love, to operate, but, for routine run-of-the-mill arthritic conditions, conservative measures should be the first thing that, should be tried. And typically what we'll do is when a patient comes to me and they haven't had any sort of conservative treatment, we usually start off with the least invasive type of methods, which would include physical therapy, and or chiropractic care, traction, decompression. A lot of times patients will have TENS units or things like that, and we try that. And if that fails or doesn't work, then we move on to a little bit more invasive things like interventional pain management with different types of injections and things like that. And then sort of if all of that fails and conservative therapy is just not working, then we look for surgical options. So
yeah, great. So another common word that people often throw around with the back-related injuries is sciatica. So can you kind of talk through what that is?
Sure. I actually get this question today, in fact.
Oh, great.
So sciatica is really another broad-based term, just like stenosis is. Typically, patients will say, I have sciatica, and they typically describe buttock pain, leg pain, that sort of shooting pain down into the extremities. And the sciatic nerve itself is actually a large nerve that's sort of in the gluteal region, and it's actually gets contributions from multiple lumbar nerve roots. So you can have, pinching of any one of those lumbar nerve roots, and it causes sort of pain down into the leg, and that's typically referred to as, sciatica.
Great. And then what kind of, I think you but maybe to elaborate on it, what causes it, basically?
Yeah, so if you have compression on a nerve root, it could be, many different nerve roots in the lumbar spine. That's what typically would cause it.
And then those symptoms, I think that you've mentioned, would be pain. Is that primarily the symptom of it?
Yeah, so pain is usually the most common symptom. It's usually pain into the buttock region. It could be, going towards the anterior thigh. It could be going to the lateral thigh. It could be going down all the way to the foot. But it also can, present with numbness, tingling, pins and needles sensation, and also weakness in certain cases in individual muscle groups.
And what is the treatment for something like that?
So in the majority of cases, in the absence of, an acute onset motor deficit, typically we try conservative therapy like, undergoing, physical therapy or traction decompression with chiropractors and whatnot, and then even injections and stuff. So
great. So we have the chat is going very crazy for you. So we have some questions. So the first, are you ready? So the first one is, I'm 2 years post three-level lumbar laminectomy. I regularly do McGill exercises. Though my sciatica is much better, I still have back pain. Beyond what I'm doing, can PT help me?
If you had, did you try physical therapy yet, or is it like sort of your first time trying physical therapy?
Let's just say maybe if they haven't tried it.
Yeah,
and then if they have.
I absolutely do think that, because certainly when you do a laminectomy and you have to strip off the muscles, there's some sort of scarring there. Things can be very tight, and certainly physical therapy can help with stretching and exercising those lumbar muscles that you don't realize you even have until you've had surgery. So I do think that it's worth trying that for sure, and I do think that it can help strengthen back muscles, in the setting of a laminectomy.
And then let's say maybe they've done PT before.
Sure.
What would you say if they're not?
So if you've gone through physical therapy, and by going through physical therapy, I mean not just going once, but actually trying it multiple times and going through, and doing it for at least a full 6 weeks. Certainly after that, there's some chiropractic care maneuvers that they can do, like flexion distraction maneuvers, or there's some things that they can do to release, try and release scar tissue. There's, depending on what imaging looks like, there's also certain types of injections that may be able to help with back pain, as opposed to targeting nerve roots. They can target actually the joints and do what's called medial branch blocks, and that can lead to things like RFAs, which is essentially, burning the nerve roots of the joints, to help with low back pain, especially in the setting of a laminectomy, because there's a lot of stress on the joints.
The next question they had is, just had ACDF surgery. I have a sore upper middle back causing chest pressure. When my back is good, I have no pressure. What exercises would be good?
Well, that's something that definitely, when the physical therapist comes, right? I know the physical therapists always like to talk about, extension maneuvers and range of motion type of exercises, but I think, he would be a good person to ask for in terms of what exercises.
Yeah, the next one was, the butt tightens up after walking short distances. Any suggestions? So that might be for the PT too, unless you have a hunch.
So if the buttock tightens up, especially with walking and any sort of motion, and say, you're walking and you get what's called a positive shopping cart sign, which I like to refer to as, if you're walking, you get that pain and all of a sudden you want to lean over.
I love that.
And that helps.
Yeah.
We consider that as a symptom of stenosis, of lumbar stenosis. So it could be the result of lumbar stenosis. Obviously, you'd have to get an MRI to look at that.
To clear that up. Great. Opinion on stem wave therapy along with PT?
Stem wave therapy. So I have not heard of stem wave therapy. There's people that talk about prolotherapy and also, there's not a lot of data on a lot of these things. I've had patients come in with acupuncture. They tried, like I said, prolotherapy. There's patients that come in saying, "Oh, I'm having stem cells injected." I can tell you there's no level 1 data on this stuff.
Okay.
So I wouldn't be able to say with any certainty that that's something that is proven. But I always tell patients, when they come to me with sort of different sort of treatment modalities, that even if they aren't sort of studied and there's no data on it, that it might be worth trying.
Yeah.
Especially if patients are hesitant on any surgery, try it.
Yeah, absolutely. Ever since my iliac strain, my back cracks constantly. Why is that?
Ever since your iliac strain?
Yeah.
Yeah, I'm not sure what is meant by that question in terms of iliac strain.
Well, maybe they'll clarify on it, and if they do, we could shoot it over to you to get some clarification on. The last one we have was, husband was diagnosed with herniated disc over 2 years ago, has had 2 steroid shots with no long-term effects. Recently has both legs in extreme pain and cannot stand. Would PT benefit him again?
I always tell patients, you could try it because there's no real harm in it. Typically if a patient has had this for many years, you've had injections already, I'd probably get an updated MRI for sure on something like that. And it probably wouldn't hurt to talk to, a surgeon in that particular situation.
Dig in a little bit more for
Yeah.
that. Awesome. Well, thank you so much, Dr. Meyers. If people at home are watching and they would like to maybe be evaluated or kind of consult with you, what's the best way for them to reach out, or where should they go?
So typically, if you call 716-218-1000, that's our main line.
Great.
That you should be able to get scheduled pretty quickly.
Awesome. Thank you again.
No problem.
And we're going to be right back. Physical therapist Chris Ponichtera is going to help teach you guys some exercises that you can add to your routine to improve your health and specifically your back pain. So we'll be right back.
This is where Leah learned to dribble, where James first picked up a brush, where Bella made meal kits for neighbors in need. This school year, many YMCAs are transforming some of their spaces for virtual learning, dedicating staff and even providing meals. So now, this is also where they will master long division, study photosynthesis, and learn when they need support, the Y is there for them. The Y, forever learning for a better us.
Pain was really bad, and it was very crippling. A lot of pain. Yeah, there were times when you thought, this is it. The main thing that it really prevented me doing was from being with the grandchildren. But the exercises that he taught me, little by little, I saw progress. I'm back to my normal life. Besides getting you better, they teach you how to live a life that will prevent you from going backwards again. They all care about the patients. That's where you're going to find your hope, and that's where you're going to feel better. I'm back.
Hi guys, we're back. Thanks for hanging in. Hope you guys got to get up, take a quick breath, maybe a drink of water, and so we can get back in and maybe change into your sweatpants so we can get some of these exercises going, right?
Yeah, exactly. Right.
All right, awesome. So I want to introduce our very own BRG physical therapist, Chris Ponichtera. You want to say hi?
Hi, nice to meet you.
Yep. So, Chris, you want to tell them a little bit about yourself and where you are?
Sure. So like Julia said, I'm a physical therapist with Buffalo Rehab Group. Born and raised in Buffalo, and I went to Damon College, one of the local schools over here. Graduated in 2018, and I've been with Buffalo Rehab Group since. So work in West Seneca. So yeah, loving it here.
Yeah, right? You're an office leader too.
Yes.
All right, so we've talked with Dr. Meyers, kind of a little bit of an introduction about the science and the understanding of how the back's really made, focusing on those discs and kind of some of the problems that you have with those. So now we're going to kind of talk about exercising with that, right? So when people are struggling with back pain, kind of talk me through what's the first thing they should know when they're starting to exercise.
Yeah, definitely. I mean, like Dr. Meyers did a nice job of alluding to, the most important thing you can do is recognizing what category you belong into. So, you know, if it's the arthritic category versus the disc herniation category, depending on what you fall into, you want to perform those exercises that are built for those, you know, symptoms. So if you're doing an exercise for stenosis that's actually built for a disc herniation, you could potentially be hurting yourself or doing more bad than good. So the most important thing you can do, hands down, is just recognizing what group you fall into.
Yeah, and so maybe for people at home too, kind of know the differences. So I think from my understanding, which I'm not a PT over here, guys, so bear with me here, but there's maybe you would exhibit different symptoms versus one category versus the other.
Yeah, sure. So we'll start with arthritis. So stenosis is the word that Dr. Meyers used, which is really just arthritis or narrowing of that canal in the spine. So those people feel a lot better with sitting. You know, they'll feel more comfortable sitting in kind of a resting position. Slouching is really pretty good, but the most common symptom is pain with walking. So Dr. Meyers even mentioned that cart, you know, that sign. That's a very common sign that we see, where it feels better to bring the angle from your chest to your thighs down. So really you're opening that space up. You're actually alleviating some of that pressure on your low back. Mm-hmm. So that's really the most common symptom with an arthritic spine. Mm-hmm. Yeah.
And then for a disc, maybe?
Yeah, disc herniation, really, the good thing about it, if anything, is it's kind of the opposite. So these people with disc herniations really feel worse when they sit. They might feel better when they lay down or when their spine is neutral. If you're standing up tall, if you're walking, that's really when that feels good. But if you're sitting and slouching, more times than not, that's when the disc will get angry and put some pressure on those nerves.
Great. So let's kind of talk about people who maybe struggle with that standing and walking long distances that you kind of mentioned.
Sure.
What are some stretches that they can try?
Yeah, so the easiest one that I do is what's called a sink stretch. And I'm just going to get some material over here so we can work on it. So the best thing you can do is, again, like I mentioned, you want to keep the angle from your chest to your thighs down and decreased, right? So what you can do is grab a chair, grab a sink or a table, whatever you can do to keep yourself nice and safe. Kind of bring your feet nice and wide, about shoulder width, and then just grab on to the front. Okay?
You're going to hold it for me?
I'll hold it for you.
This is not a sink.
Yeah, so
Don't
make
try
sure
this at home.
Safety as much as you possibly can.
Yep.
So those knees are going to be nice and straight, not totally straight. Keep a little bend in it. And then all Julia's going to do is just kind of lock her butt down and then just get a nice stretch in through her low back, her hamstrings, and, you know, all different regions that can contribute to how that back moves. When I give this in the clinic, and this is one of the most common exercises I use, really I'm telling patients, hold it for 10 seconds at the bottom. And I like it, 10 repetitions is really pretty good to do it the most. And again, gentle. You want to let your body do the work. Kind of let your butt just sink down like Julia's doing, and you don't want to have excess strain or anything that's going to really contribute to more back pain. So nice and gentle on this, okay? Handful of times a day. This is an easy one you can do.
Great. What else you got for me?
Yeah, so the next one I have, it's easy kind of a sit to stand, right? So all we want to do is work those muscles best as we possibly can. So really, we're going to use the chair again. So we'll spin this around. I'll have you have a seat. And again, the motion is going to be anything we can do to bring our chest down to our thighs. So we want to decrease that angle. So we're going to kind of increase this a little bit. And what Julia's going to do is she's going to sit.
It's a tall chair.
Yeah. Well, in general, you'd have a smaller chair, but this will get the job done.
I think we can snag a smaller one.
We can snag a smaller one?
Yeah.
Okay.
Let me grab one.
That's fine.
Don't worry, guys. I'm setting you up for it to see it at home. It's
Safety first always, okay?
Yep.
So this is a little bit more of an appropriate chair. So Julia's just going to sit, and what she's going to do, it's literally a sit to stand. It's in the name. So she's going to stand up and sit down, but we're adding something to it. I want her arms to reach forward. So she's going to reach in front of her, come up, and then come down, okay? And you can feel this in the front of the thighs, and really it's a nice strength building exercise to help those thighs, to help those glutes, those muscles that help the back move a little bit more. So, and again, decreasing that angle is going to open that space up in the back. So we're kind of killing two birds in one stone on this one. Since this one's more of a strength exercise, I like 10 repetitions here. Nice.
How
and
many
gentle.
times?
Yeah, 10 times total, up and down. And then
Any reps?
two or 10
Or
repetitions. One set, 10 repetitions, 2 times a day.
Okay,
So that should
great.
be a little more clear. Okay, so the last one I have is actually a lunge, so we don't need any material for this one, which is nice. So this one is still working on that strength, the strength of the hips and the thighs to best help out the back. So what Julia's going to do, same idea as we're reaching forward while we do it, but it's a lunge to the side. We want those side muscles to be doing what they need to be doing. So Julia's just going to take a step to her right and reach her arms forward. Good. And then come back. And then come back to the right again. Very good. And then generally when I do this, I always want to do it both ways. There's no reason not to do it both. So I like 10 to the right, 10 to the left. You can either alternate or do 10 in a row, whatever's more comfortable, but you always want to make sure you're keeping those arms nice and in front of you, nice and relaxed with this, okay? So again, treat this like you did with the sit to stand, just in the sense that you want to be a strength exercise, so let's keep it 10 repetitions, one set, 3 times a day is a safe bet for just this kind of strength building exercise.
And am I doing like a little bit of a forward bend with it usually, too?
Yeah, so you want to kind of hinge your hips and bring that arm forward.
Why are we trying to go forward?
Yeah, so when we go forward, again, that angle between the chest and the thighs decreases. That actually opens up pressure in the low back. Someone with arthritis needs that pressure relief, so that's going to be a good way just to reduce some of that inflammation during it.
Great. So, all right. Sink stretch, sit and stand, side lunge, right?
Excellent.
Great. So now let's kind of walk through some people with maybe the opposite problem, right? So they do okay standing, walking, but they hurt sitting.
Yeah, exactly. So this is more of that disc herniation category that you fall into, as opposed to the stenosis and the arthritis category we just kind of talked about. The easiest one I can do is kind of the equivalent of the sink stretch, but instead of going forward, I just want to go backward. And the nice thing about this is you can do it just standing up. So feet about shoulder width apart, and then Julia's just going to put her hands on her hips, make it as easy as she can, and just gently bring back. I always tell my patients, pretend like your chest is just kind of falling back, and really go till, just like the sink stretch, go until you feel a gentle pinch in your low back. You never want it to be sore, gentle pinch, and then you hold that for a second, and then come back. Go hold it for a second and come back. Dr. Meyers kind of alluded to that. This is one of those extension-based movements that we work on as physical therapists to kind of push that disc back where it needs to be in the contents of that disc, reducing pressure on that nerve.
Great. How many times?
I like, that's an easy one. It's kind of like the sink stretch. You can kind of do it as needed. Usually I tell my patients if it's really flared up and you know for a fact you're in that disc herniation category, 10 times an hour or every other hour really is a pretty solid plan for that. You can't overdo it and you're not going to hurt yourself by doing it.
Yeah, and it's nice too. I'm thinking about, especially if you have maybe a desk job or you sit a lot too.
Definitely.
Like you should be getting up every hour to move, so that's a good one to really open yourself up while
easily.
you're sitting down too, versus being hunched over.
Yeah, gives a reason to stand up on top of that.
Yep.
Yeah.
All right.
Perfect. We'll grab the stool for this next one.
I'm your equipment.
I appreciate it. So what we'll do for this one, we want to work the front of the thighs, and this is a nice stretch. This is a stretch that really I do every single day, and it's a really nice whole body stretch. But what I'm gearing towards is we want to, kind of get out of this posture and into this posture when we talk about disc herniation. So we don't want to be creeping forward. We want to be staying nice and back. So keeping that front of that hip nice and loose is going to be huge for how the back moves. So that's what the gear of this stretch is. So Julia is going to take a stool. In this example, we have a stool, but at home, generally a stair or two works fine. And just like the other stretches, you always want to be safe. Make sure that you're hanging on to something. If that means the wall, if that means a railing, whatever you can grab onto, that's going to be best. So Julie's going to put one foot on it. It doesn't matter which one. And then her back leg, in this case, her left leg is going to be nice and straight. And all she's going to do is keep herself nice and upright and bend that right knee. Should feel that in the front of that left leg, okay? Nice little stretch there, right?
Yeah.
Important to keep that back leg straight, just like you're doing. And you don't want to creep forward into it. You don't want to let that chest come down. Keep yourself nice and upright. Until you feel that stretch in that front of that thigh, really that's what we're shooting for here, just to take some of that pressure away, okay? So when I get there, I hold it for about 5 seconds, okay? Then I do about 20-ish on each leg. 20 seems to be fine because that muscle is going to want to be tight. Right when you sit down, it's going to go back to being tight again. So you want to keep it as mobile and as loose as you can, producing that long-term change.
Do it this way too for them.
Yeah, sure.
So I think the important thing that I've learned when I did this too is that your foot should be straight, the back foot too, right?
Exactly.
So not at an angle, like pigeon toeing out.
Yep, feet flat on the ground and both feet flat on the ground, and the back knee really should be straight too if you can tolerate it.
And heel down.
Exactly. Keep that heel nice and down.
Great.
Okay. Perfect. I got one last one, and it's kind of like that lunge that we did to the side with the patients in the stenosis category. Instead of going to the side, we're going to go forward, but we're going to kind of use our arms to help us get better movement in the lumbar spine to take some of that pressure away from the disc. So it's a lunge, and we can show it different ways, but what we can do first would just be to take a step forward. So it's just a gentle lunge forward with either leg, and Julia's going to take her arms and swing them overhead and kind of look up to those arms best she can. What that does is it puts a little bit more of an extension force on the low back, and that's like we talked about with that standing movement before. That helps to really get that disc moving how it's supposed to be moving. So using those hands as a driver really adds some more tension to the low back. It really needed tension for that. So alternating when I do that, usually how I suggest that to patients, 10 times each side. Again, you can alternate, do 10 in a row, whatever's most comfortable for you, but really we want to be doing both sides and, getting those arms up, and the head can follow too. You'll get a really nice stretch in your mid-back on top of that. Perfect.
Great.
Good.
All right. And then not really having to go too low into the lunge, right?
Yeah, I mean, it's we want to build as much strength as we can, but really the purpose of that exercise, among other things, that extension force backwards really helps the disc the most. So you're kind of, you're working on the strength, but you're also kind of pushing that disc material back where it needs to be.
Great. So backward bend and extension, really. Then doing like the gait and chair stretch, and then the forward lunge with the overhead reach.
Excellent.
And how many did you say for the forward lunge?
For the forward lunge, it's a strength exercise. So just like the other lunges, we want to do 10 on each side, and one set of that 3 times a day is probably fine.
Awesome. Yeah. So kind of talk through in terms of, back pain, maybe like the importance of core strength.
Sure. So we see that all the time. Patients come in and, they talk about weak core, and their doctor told them they have a weak core. Realistically, the job of the core is to prevent us from falling down. You see patients doing crunches, and you see things like, sit-ups and some crazy exercise patients are doing, which works for people. But if you're in a disc herniation category, for example, and you're bending forward, we know that can put a lot of strain on it. So something like that, the job of the core is to keep the body upright. It's also to stabilize the spine. We don't want the lumbar spine moving too much. We want to keep it nice and still. And what the core does is it keeps that nice and still. So we want to be doing exercises where we're upright, not as much of the rotating or as much on machines. We want to be as upright as we can and work some exercises there.
And for people that are watching at home, can you kind of just explain what the core is? Because I think a lot of people just naturally think just your abdominal muscles.
Yeah. So as nice as it would be to have a six-pack, that's not all of it. I don't think I'll ever get there. But as nice as that would be, really the core is anything on both sides of the body, from below the chest really to the middle part of the thighs. And again, those muscles stabilize. So those, the hips are part of the core, the chest is part of the core, the stomach is part of the core, the low back is part of the core. These things have to work together to make the spine move, right? So you kind of think of like a sandwich, the upper core, the lower core, then you got muscles on the side, there's everything, but really they compress the low back. So that's the importance of the core.
Awesome. So I think we had a few questions from the audience.
Sure.
So Dr. Meyers had a couple, and I think you do too. So first one is, I have 2 compression fractures and 6 bulging discs. It has been 5 months and I am still in pain. Will PT help or hurt?
Yeah, I mean, it's definitely would help, and everyone's different in the sense that everyone has a unique story and where they're coming from and what happened and how they got there. But, anecdotally speaking, there's a lot of patients that come in and they've had pain for 20, 30 years, and really it's not the back's fault. It's we need to be working on the hips, or we need to be working on the core a little bit more. So sometimes just because you've had pain for that long, and it's really unfortunate to hear that, it's not the back's fault. It's the other things that aren't moving correctly. So really what physical therapy would do would attack what's not moving correctly to free the spine up. And that's where patients get a lot of relief.
Yeah, I always think it's important of like when you think about maybe like a bridge or something, like an actual bridge that you drive over, like it wouldn't just be one part, it's the entire bridge that works together for the cars to drive over it.
Exactly.
So that's like your body, right?
Sure. I can start using that one. That's pretty good. Yeah, but that's a perfect example is everything needs to work together, and when something doesn't work the right way, that's when problems happen. So that's what we do, is we fix what's not working correctly.
And then the other one, Dr. Meyers had a question that he thought would be good for you, but so they just had ACDF surgery. They have a sore upper middle back causing chest pressure. When his or her back is good, he has no pressure. What exercises would be good for that?
Yeah, so I mean, we see that a lot with patients who have had a lumbar surgery, and maybe that type of surgery is something that's very, very common in what we see in the clinic. what happens is the other parts of the body start working a little bit too hard. So when we get like middle chest issues, thoracic spine issues, that upper part of the chest, what's going on is that thoracic spine is working too hard because the lumbar spine isn't working hard enough. So what we need to do is get anything we can do to keep ourselves upright. So, without seeing this person, I hope everything clears up, but without seeing this person, I tend to think that some of the stretches that we do for the extension movements would be a little bit better, but gently. But, obviously it's different from patient to patient, but in general, I think those would be the go-tos.
And then the last one they have is, so they had an MRI, it revealed bulging discs in 2 places where vertebrae are not aligned with the next one. Mm-hmm. PT or surgery? Yeah,
I mean, it's always, conservative therapy. We see that all the time with patients who have MRI reports, and the MRIs are scary. But there's all these studies out there that suggest with the MRIs that just because it shows up on the MRI doesn't mean it's like a death sentence, for example. You don't need to be written a script immediately for surgery. Dr. Meyers mentioned a lot of these patients clear up conservatively without having to go to, surgery or down that surgical route in the first place. So I think, again, it comes down to what's not moving the right way rather than just the spine. If there is all the herniations there and everything else going on, oftentimes it's just because something's not working appropriately, and we need to get that moving better to best help that out.
Yeah, and I think what's great too is you guys work really closely with obviously other members of the healthcare community,
Definitely.
including physicians, people like Dr. Meyers. Mm-hmm. So if they, utilize physical therapy, for some reason they need additional steps forward to maybe talk to a surgeon or something like that, you guys can coordinate that with them.
Of course, we're in constant communication with them all the time. So they always know where our patients are at. If we feel they need more steps down the line, like Julia kind of alluded to, we do offer that all the time as well.
Great. And then the last one, you're very popular tonight, Chris, is that you had 2 spinal fusions and neck fusion. What do you recommend? Any exercises?
Yeah, I mean, when there's fused, obviously fusions between the joints are stiffness. So you don't have as much motion in the spine as you once did, especially if we're dealing with the cervical spine too. Stretching in general is probably the move. Just stretching in core strength to best support what's not moving the right way. Get as much movement as you can out of the other parts of the body that aren't fused or don't have any surgical procedures involved in them. And that's really going to give you the most relief, I think.
Great. Well, thanks, Chris.
You're welcome.
And if people want to kind of get in touch with you for more of like an individualized plan, or maybe they realize after this that PT would be something, helpful for them, how can they reach out to you? Yeah,
so we have the central number that will be sent out to everyone on top of that. And my email is just chris@buffalorehab.com. If there's anything I can help you with, let me know.
Great. And obviously we reviewed a lot tonight, so all of the exercises and stretches that Chris talked about for both groups are going to be sent, so keep an eye out on your email. Thank you guys so much. Thanks, Chris.
Thank you.
And